Hi, welcome to Nurse Ed Scholar. So, if cardiac questions kind of make your heart rate go up, you're not alone. You know, acute coronary syndrome, heart failure, dysrhythmias, hemodynamics, these are some of the most feared topics on the NCLEX. But here's the truth. The NCLEX is not really testing if you can memorize every rhythm strip. It's testing if you can recognize instability. Do you know how to protect perfusion and how to choose the next best step? So today we're going to pull everything together and we're going to go over some NCLEX style cardiac questions. And hopefully by the end of this video, you won't panic as much when it comes to cardiac questions. So before we can begin, let's look at a decision framework. Now, every cardiac NCLEX question can be, kind of filtered through with three questions. So number one, is the patient stable or unstable? Is the perfusion adequate? And what is the immediate safety threat? Cardiac is not about memorization, technically. It's about stability and perfusion. So if the brain and the organs are not being perfused, nothing else matters. So let's think of stable, the definition of stable. Stable would be normal blood pressure, awake, alert, and oriented. They're warm. They have adequate oxygenation. And then you have an unstable patient. They'll present with hypotension. They'll have an altered mental status, uh, chest pain, even signs of shock. So understand, stability always outranks a diagnosis. So let's begin. Okay. So you have a 62-year-old male coming in with crushing chest pain radiating to the left arm. Blood pressure 92 over 60, heart rate 118, respiratory rate 24, oxygen saturation 90%. They're diaphoretic and they are anxious. All right. So what's the priority? Do you administer morphine? Do you obtain a 12 lead EKG? Are you going to apply oxygen? Or are you going to do discharge teaching? Okay. So think about it for a second. Okay, let's move on. So let's walk through this. Is the patient stable? No, they're hypotensive and hypoxic. So what is life threatening? Well, the low oxygenation. So your answer would be C, apply oxygen. You're like, well, why? Well, airway and oxygenation comes first. You can't treat ischemia without oxygen. So notice that, you don't panic when it comes to the diagnosis. You want to stabilize the patient first. Okay. So stability always outranks the diagnosis. Let's move on to number two. All right. So you have a patient with heart failure, with worsening shortness of breath. On the assessment, they have crackles in the bases, 3+ pitting edema. They've gained 4 pounds in weight in 2 days. Their blood pressure is 88 over 54, and they are confused. So, what is most concerning? Is it edema? Is it the crackles? Is it the low blood pressure? Or is it the weight gain? Okay, so think about it for a second. All right, let's walk through this. Students typically choose, oh my God, they have crackles, right? But you got to ask yourself, what kills the patient first? And it would be the low perfusion. So the answer would be low blood pressure. What was it, 88 over 54? You know, edema equals a fluid problem, right? But the hypotension, the confusion shows you that it's a perfusion problem. And perfusion of those organs are going to always outrank fluid overload. Okay. And that's what I'm trying to get you to understand. All right. Let's move on to scenario 3. All right. So you have a patient on telemetry. They develop atrial fibrillation. Their heart rate is 140. Their blood pressure is 118 over 70. They're alert. No chest pain. Okay. So what's the priority? Do you call the code blue? Do you prepare for synchronized cardioversion? Do you monitor and notify the provider? Or do you begin CPR? Think about it. Okay. Is the patient stable or unstable? Well, they're stable. So what does that mean? That means that you do not shock stable patients. So the correct answer is C. You are going to uh, monitor and notify the provider. Dysrhythmias are not about memorizing those rhythm strips or it's, you always got to ask yourself, is the patient stable? Because stable dysrhythmias are treated medically. Okay. Remember, the patient was alert. They didn't have chest pain. Okay. All right. Let's move on to scenario 4. All right. You have a post myocardial infarction patient, so a post MI patient in the ICU. Their MAC is 58. Urine output 10 milliliters an hour, full extremities, heart rate 122. So, what is the priority? Do I increase fluids rapidly? Start vasopressor? Give morphine? Or elevate the head of the bed? So, think about it a second. Okay, so let's go through this. Remember, the map was 58. It's less than 65, so you know that there's inadequate perfusion. The kidneys are not being perfused because also think of it, the urine output was 10 milliliters an hour. It's supposed to be 30 at least, at minimum, right? So if the brain and the organs are not being perfused, that is the problem. Okay. So the answer is B, start vasopressor. Why? Fluids are not going to prevent cardiogenic shock. Pressors will support the blood pressure, perfusion pressure, because remember, pressors increase blood pressure and it increases cardiac output, which is going to help perfuse the brain and the organs. Okay? All right. Scenario 5. All righty. You have a 70-year-old female, history of heart failure and coronary artery disease. They're coming in with chest pain and shortness of breath. Blood pressure 84 over 50, heart rate 128, respiratory rate 28, O2 sat 88%. What are you going to do? What are you going to do? Think about it. This is where students panic. All right. Is the patient stable? No way. What is going to kill her first? You got that hypoxemia, that 88%. You have that hypotension, right? So what can you do? You're going to give that person some oxygen and you're going to call a rapid response. Okay. You're not going to look at labs. You're not going to try to start teaching the patient. You're not going to do any documentation. For this patient, you need stability. You need to protect this person's life. Okay. I think sometimes students get mixed up because they're like, okay, well, unless it has been told to you that interventions are assumed order, right? You have to do what you are going to do in the scope of, or what are you going to anticipate? So it's kind of like with this patient, there's no other orders. There was nothing else to think of. So you're going to anticipate because looking at the responses well, there was no responses with this one. But the first thing that you're going to think of is I have to call a rapid response. Now, if this was a question that had picking responses, you would always pick the response that is going to stabilize the patient first, and then either call a rapid response if that is an answer choice, if it's to give a pressor, but you always have to think of what is affecting perfusion or what is going to kill the patient fastest. Okay. And so, why do cardiac questions feel hard? You know, um, you know, even, when I was a student, everybody fears cardiac because there are a lot of numbers, there are a lot of medications, there are rhythms, there's acronyms, but the NCLEX simplifies it to perfusion, stability, and safety. If the blood isn't moving properly, that's the problem. Everything else is secondary. Okay. Now, these are common traps that you'll see on the NCLEX, and with students, we see that students do this in academia. Number one, treating pain before oxygen. We always see this. You know, the oxygen, yes, the patient is having crushing chest pain, but their O2 sat is 82. You need to put some oxygen on them first because if they have ischemia, you controlling the pain is not doing anything to the injury to the heart. All right, and trying to get those organs perfused with and then trying to get them oxygenated. So don't treat pain before oxygen. Memorizing rhythm strips instead of assessing your patient. Just like the atrial fibrillation question. The patient was fine. But if you see that rhythm and you panic and you think you need to do something, but the patient is talking to you, they are alert, they are awake, you don't do anything. Okay. Ignoring the map. Sometimes students miss if the map is less than 65, because if it's less than 65, you know that there is a perfusion problem. Sometimes students just skip right on over that. Treating edema before hypotension. The patient is already hypotensive. You give them some diaphoretics for that edema, you're going to lower the blood pressure even more. So watch out for those. And jumping to advanced interventions before looking at airway, breathing, and circulation. Okay. The NCLEX is not trying to trick you. It's trying to see if you will panic. It's trying to see if you can determine stability, what is going to stabilize your patient, what is going to protect your patient. And they want to see if you're going to panic and freeze. And that is what they're trying to assess. Okay. And so remember, we kind of went over this in the beginning. We're going over it now. Before answering any cardiac question, you want to know, is the patient stable or unstable? Is the perfusion adequate? Is that MAP greater than 65? What would kill this patient first? And what action protects life fastest? Remember, stability is always more important than a diagnosis, and perfusion is always greater than memorization. If you kind of can remember that sequence, that will help you a lot when it comes to cardiac questions in school and on the NCLEX. I hope this helped. I hope this whole cardiac series kind of gave you some background and kind of helped reduce some of your anxiety. I really hope so. Um, Please subscribe, so you don't miss any more high impact NCLEX breakdown videos. You know, if you want some structured scenarios, decision trees, for this cardiac priorities and any of the series, I create workbooks to kind of give you something tangible that you can work on at your leisure that will help bring all of this together on nurseedscholar.com. Remember, you don't need to memorize everything. You need to think safely. And that's what we're trying to build here on Nurse Ed Scholar. So please like and subscribe, turn on those notifications, and until next time, happy studying from Nurse Ed Scholar.